Yes, sir.
Yeah, it's done.
Yes. So, sir, we are starting the session, sir.
Okay.
So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare. Welcoming you all for today's webinar. The topic for today's webinar is hypertensive disorders in pregnancy. So, I welcome all the audience. I request them to post their queries, if any, in the chat box so that we can have a short Q&A session at the end of this presentation. And now it's time to introduce our invited speaker for the day, Dr. Gaurav Shete, sir. Sir has done his MBBS and MS OG from KIMS, and sir is a gynecologist and obstetrician and is practicing in AMIA Fetal Maternal Medicine Clinic, Mumbai. So sir is very much interested in sports and is a very good sports person also. So with this short introduction, I welcome you, sir. I'm handing over the session to you for further proceedings, sir. Thank you, sir.
Thank you. Thank you so much. Thank you, Mr. Stalin. So good evening to everyone. I hope all of you are doing well. So today's topic of discussion is going to be hypertensive disorders in pregnancy. Initially this was labeled in a very broader way, proximia of pregnancy and all. Now they have consolidated all these terms, preeclampsia, eclampsia, everything, gestational hypertension, chronic hypertension, into one big umbrella. And the recently coined new term for all this is hypertensive disorders pregnancy, or HDP. Okay, so let's start. So definition of hypertension in general, okay, male or a female is defined as a blood pressure more than 140/90.
Yeah. Excuse me, sir. Your screen is not shared, sir.
Oh, okay. I'll just share my screen. Okay.
Yes, sir. Sir, can you make it in slide share mode?
Yes.
Yes. Thank you, sir.
All right. So we'll go forward now.
Yes, sir. You can carry on, sir.
Okay. All right. So definition of hypertension in general is a blood pressure more than 140/90. Systolic BP taken on 2 occasions should be more than 30 mm of mercury parameter, and diastolic more than 15. Okay, observed on 2 intervals 4 to 6 hours apart. Now, hypertension in pregnancy and hypertension in general, the definition is the same. But hypertension in pregnancy is always a dreaded complication, which is usually called as the worst nightmare an obstetrician can ever encounter, because the sequelae which takes place, okay, is not the same that takes place in a non-pregnant patient. Okay, if there is a man or there is a non-pregnant lady in front of you who's having a BP of 140/90, yes, it is a physician's role to come into play and control the hypertension. But when the same lady is pregnant and her BP is 140/90, we as an obstetrician have to be very cautious. We have to be very careful about the timing of delivery, or the complications that the raised BP might cause, because one of the severe complication is eclampsia, and eclampsia by itself means a bolt of lightning. It comes as a flash. Okay? It doesn't give you any warning. It comes as a flash. So if the BP in a pregnant lady is not well controlled, it might lead into severe complications like eclampsia and even maternal and fetal death. Okay. So hypertension again is defined as a blood pressure more than 140/90. Okay. Now there are 4 variants to this. There is gestational hypertension, there is preeclampsia and eclampsia syndrome, there is chronic hypertension, and there is preeclampsia superimposed on chronic hypertension. So now gestational hypertension is defined as BP more than 140/90 without proteinuria after 20 weeks of gestation, 4 to 6 hours apart. Okay, it is the commonest medical disorder which is diagnosed in pregnancy, and spectrum rise from mild, moderate to severe. So it is it complicates almost 5% of the pregnancies and 11% of the first pregnancy. So this states the risk factor as primary gravidas. So first time a lady is subjected or exposed to chorionic villi, she's having a higher risk. Okay, eventually the risk of the subsequent pregnancies goes down. Okay, so that is a leading cause of maternal mortality. Accounts of 40,000 maternal deaths annually. India is 30% of maternal deaths. So preeclampsia, eclampsia deaths, okay, are 30%. After that, there is PPH. So we have to be careful because this is a severe cause. This is one of the major causes of maternal deaths. So epidemiology, leading cause of deaths, okay, complicates about 2 to 10% of the pregnancy. Okay, incidence is higher in developing countries. So even ethnically, if you see, Indian and African populations are more prone to this disease. Is Southeast Asian as well as African countries. Their ethnicity, the people staying in these countries and continents are more prone to having preeclampsia than anywhere else in the world, almost 7 times more than the developed countries. All right. So like I discussed, there is chronic hypertension, there is chronic hypertension superimposed with preeclampsia, there is gestational hypertension, and there is preeclampsia, eclampsia syndrome. So this chart will give you a little brief idea. So chronic hypertension, as you see, is below 20 weeks. Chronic hypertension means the lady has been diagnosed hypertensive before 20 weeks. She can be even diagnosed before pregnancy itself. So she might be existing hypertensive patient who's already on medications, then she's gotten pregnant, and now we have to continue the pregnancy, look at her as a chronic hypertensive patient. We have to just change the drugs which are suitable for pregnancy, usually labetalol. Okay, then comes if the pregnancy, if we detect that there is 20 weeks, it's usually gestational hypertension if there is no proteinuria. Okay, there's preeclampsia, eclampsia, or else if there is chronic hypertension and suddenly we see that there is a proteinuria now, or there is BP which was initially well controlled and now it is suddenly increasing. So that means there's a superimposed preeclampsia on chronic hypertension. All right. So before 20 weeks, like the same chart, okay, we'll give you a brief idea. Eclampsia, so gestational hypertension is BP more than 140/90 without proteinuria. Preeclampsia is gestational hypertension with proteinuria, and eclampsia is preeclampsia with seizures. Okay, so now different organizations all over the world have categorically divided preeclampsia, eclampsia, gestational hypertension, like HDP, into broader perspective, into their own definitions. So American College, Hypertension of Canada, Society of Cardiology, Society of Canada, okay, all these people have in general defined hypertension in pregnancy as mild, moderate, severe, or severe to non-severe. So we'll see that later. Okay, so now we'll discuss about gestational hypertension or transient hypertension. Okay, so BP is 140, patient's BP is more than 140/90. Okay, a patient has crossed 20 weeks of gestation. The BP has been checked on 2 occasions, 4 to 6 hours apart to confirm this, and there is no proteinuria. And BP and the final diagnosis is only after delivery, after 12 weeks post-delivery. Okay, so that is why if the BP returns back, okay, after delivery, till 12 weeks, okay, it will be defined as gestational hypertension. Okay, next. So preeclampsia is BP 140 more than BP 140/90 after 20 weeks of gestation, and any one of the following. So initially it was only proteinuria. Sometimes we do not get proteinuria, but we do get oliguria. Okay, we get liver, and basically it is a multi-system involvement. Okay, if you see the definition, it's a multi-systemic involvement of a patient. Okay, not only the BP, it's also the kidneys that are elevated, also the liver that is affected, also the CNS in the brain is involved, hematological disturbances are there, even the fetus is involved, and it can also lead to pulmonary edema. So even lungs get involved. Okay, so if any of these signs are seen in any of this thing, it is called as preeclampsia. So proteinuria more than 300 mg or 0.3 gram per 24 hours, or dipstick 1 or +1. Okay, oliguria, elevated liver enzymes, epigastric pain. Okay, the epigastric pain is due to stretching of the liver capsule. Okay, then there is altered sensorium, there is decreased platelets, and okay, there is iugia. Then comes eclampsia. Eclampsia is convulsion in a patient with preeclampsia, occurs antepartum and also may occur 2 weeks up to postpartum if the BP is not well controlled. Preeclampsia superimposed on chronic hypertension. There's a new onset of proteinuria after 20 weeks of gestation. There is aggravation hypertension, okay, and the BP was initially well controlled on say one antihypertensive. Now the BP has started shooting up. Probably have to increase the dose of the same antihypertensive, or probably even have to add one more antihypertensive. Okay, the platelet count steadily starts going below 1 lakh. Chronic hypertension is BP 140/90 before 20 weeks of gestation, or persistent after 12 weeks. So if the BP you find persistent after 12 weeks, you have to label the patient as a chronic hypertensive. All right. So in preeclampsia, like we discussed, there is a liver involvement. There can be pulmonary edema. There can be cerebral symptom. There can be renal insufficiency. There will be thrombocytopenia. Okay. Now, what is the pathogenesis? So, if you look at the embryology of the developing fetus, there are 2 waves of trophoblastic invasion. So, first there is chorionic villi. They invade at around 8 to 10 weeks. Okay, they go up to the decidua of the spiral arterioles, and they destroy the muscularis layer. Okay. After that, the second wave of trophoblastic invasion usually takes place from 16 to 18 weeks. Right. At that time, the spiral arterioles which are there in the myometrium are invaded by the syncytial trophoblast. Okay, and once these are invaded, okay, by the trophoblastic cells, the muscularis layers in the muscularis part of the spiral arterioles in myometrium are destroyed. So because of that, the arterioles, okay, they become more of a venous system rather than the arteries by themselves. They do not respond to the maternal hormones because there is no muscularis layer left. So this happens in normal pregnancy. In preeclampsia, the second wave of trophoblastic invasion doesn't take place, because of which the sequelae of preeclampsia starts. So if there is a failure of conversion of spiral arterioles to vascular sinuses, there is placental ischemia. So when there is placental ischemia, it causes effect on the fetus and as well as the effect on the mother. So the effects on the fetus are like there is narrowing of the spiral arteriole, so the blood supply to the fetus is reduced. There is IUGR, there can be preterm delivery, and in severe cases there can be fetal death. In mother, what happens is there is the release of various endothelial substances from this placenta. Due to the ischemia, these substances are released. Okay, substances like thromboxane A2, there is decrease in PGI2. There are nascent oxygen radicals are released. Okay, there is angiotensin II sensitivity is increased. Okay, because of all this, there is this causes vasoconstriction. Okay, there is poor renal perfusion. There is vasoconstriction, there is proteinuria, and there is edema. And if this is untreated, this goes into severe hypertension. There is vascular congestion. This goes into cerebral edema, and this can cause convulsions later. So this is the normal, how the left side picture states how the normal pregnancy, the spiral arteriole looks. You can see it has turned into a venous sinus rather than an artery now on the left side, while on the right side you can see the smooth layer, muscular layer of the spiral arteriole is still intact because the trophoblastic wave of invasion has not yet reached there, because of which it is still responds to the maternal hormonal changes. Okay, because there is also constriction in preeclampsia. So preeclampsia disorder is a disorder of endothelial function. It's a disorder of endothelial function with vasospasm. So all this placental ischemia that is caused releases a lot of harmful toxins, you can say, which enter the maternal blood circulation. And once it enters the maternal blood circulation, it usually causes endothelial cell damage. So endothelium, which usually doesn't allow blood to clot or cause vasoconstriction, is because of continuous secretion of nitric oxide, NO. Okay, because of which there is no vasoconstriction. But once because of these toxins, there is damage to the endothelial layers, there will be consumption of platelets, there will be consumption of fibrin, there will be release of more toxic substances which cause vasoconstriction, and this might also lead to DIC and HELP syndrome. Okay, so there is diffuse placental thrombosis because of the narrowing of the placental vessels, inflammatory placental decidual vasculopathy. There is abnormal trophoblastic invasion of end arteries. Okay, there's altered maternal immune response. So one of the theories is there is maternal response to the fetal tissue. Usually, there is the maternal blood doesn't have any immunological side effects from the fetal tissue, but in preeclampsia we say there is some altered immunological response which causes increase in NK cell activity toward the fetal bloods, and because of which again there is endothelial cell damage in the maternal circulation as well as vasoconstriction at the placental beds, which causes decrease in the blood supply to the fetus as well. So abnormal cytoplasmic invasion. To sum it all, there is abnormal cytoplasmic invasion, there is decreased uterine blood flow, there is placental ischemia, placenta release cytokine factor, there is endothelial dysfunction. Okay, there is increase in thromboxane A2, decrease in PGI2, there is increase in NO, and there is angiotensin sensitivity increases. It causes decrease in renal pressure and causes hypertension, and there is vasoconstriction. Then now preeclampsia is AICUG differentiates into severe and non-severe, and nice category defines it as mild, moderate, and severe. Basically, it is BP from 140 to 150 systolic, 150 to 160 systolic, and more than 160 systolic. Same for diastolic, 90 to 100 and 100 to 110 and more than 110. While in AICUG criteria, the systolic BP from 140 to 160, okay, less than 160 you can say, and more than 160, right? So you see mild and severe. Mild is BP less than systolic BP less than 160 and diastolic less than 100, while severe is more than 160 and more than 110. Okay, so there is proteinuria. In mild cases it is less than +2, in severe cases it is +3. Other symptoms like headache, visual disturbances, upper abdominal pain, oliguria, convulsions are present in severe cases while not present in the mild cases. Liver enzymes are minimally elevated in mild cases, and there is no thrombocytopenia. Well, there is no fetal growth restriction. The Doppler studies don't show any significant changes, and there is no pulmonary edema. But while in severe cases, all these things you can see. Same with if you go for non-severe and severe, less than 110 and less than 160 for non-severe. For severe is more than 160 by more than 110, and other signs that we discuss are the same. Now, what are the high risk? Who are the high risk groups? Like we said, Indian population, ethnically, we are more predisposed. Okay, younger the age and more the age. So, any girl who is getting pregnant before the age of 18, or else ladies who are getting pregnant after the age of 35, okay, they are more of a high risk groups and who are more predisposed to developing preeclampsia. Then there is obesity. There is first time patients who are exposed to chorionic villi, so the primary gravidas, so low social pre-existing vascular diseases like diabetes mellitus. Okay, and previous pregnancies probably or something which causes more exposure to chorionic villi will be twin pregnancy, multifetal pregnancy, polyhydramnios, and iridiform mode. So the risk factors for chronic hypertension is almost 15 to 40%. For pre-gestational diabetes mellitus, it is 10 to 35%. Connective tissue disorders is 10 to 20%. Thrombophilias, obesity, all from 10 to 15%. Older than 40 years is 10 to 20%. Okay, limited foam exposure, 10 to 15%. Patients who are on ART, nowadays we have realized even those patients are high risk, okay, for developing preeclampsia. All right. So etiology is not known. It can be genetic, it can be immunological, it can be dietary deficiencies of zinc, calcium, and magnesium, but it has not been proved yet. And there is the placental ischemia. But what we can conclude is the source can be placental ischemia, because as soon as the placenta is removed, as soon as after delivery, once the placenta is removed, the BP usually in 80 to 90% of the cases, it comes down and it is well controlled as soon as the placenta is out. So placenta is a major source. All right. So major source and defect is relative deficiency of prostacyclin versus thromboxane. So normally in a non-preeclamptic patient, there is increase in prostacyclins as well as increase in thromboxane. Okay, thromboxane A2 to be more precise, and PGI2 for prostacyclins to be more precise. So prostacyclin PGI2 usually increase 8 to 10 folds, while thromboxane increases 1 to 2 times. All right. So prostacyclin usually causes vasodilatation. There is decreased platelet aggregation as well as decreased uterine tone. While in preeclampsia, this ratio is altered. There is increase in thromboxane 8-2 and there is decrease in prostacyclins. Okay, because of which the ratio is altered and patient is more susceptible to preeclampsia. Now the role of aspirin. So aspirin has been given as a prophylactic treatment to avoid preeclampsia and to prolong the duration of pregnancy. Aspirin is basically anti-thromboxane production, it's basically anti-thromboxane activity. Okay, as we know that there is hemoconcentration in pregnancy. In preeclampsia, because of vasoconstriction, there is even further, you can say there is even further hemodynamic changes take place, which makes the blood even more. There is even more coagulation. There can more chances of coagulation, because of which aspirin is given. All right. So there was a study that was conducted in 1994, which states that 60 mg of aspirin was given. The small reduction, 12% reduction was seen in PIH cases, and small percent of reduction in preterm deliveries, almost 20 to 22%. But there was no difference in the neonatal outcome. Whereas later a study was conducted in 1998, which stated that usually there is no reduction in development of preeclampsia, then there is no significant perinatal outcome. So pathophysiology. So what are the systemic effects of hypertensive disorder of pregnancy? First, there is cardiovascular, there is respiratory, there is renal, there is hepatic, there is hematological, there is neurological, and fetal. So as you see, like I discussed before, there is a multi-system involvement. Like in a non-pregnant patient, the hypertension will not severely take down all the systems. Okay, it will eventually, if it is not well controlled over a period of time, gradually over the years, it will start causing changes in this system. But in pregnancy, this process is accelerated. Okay, you can suddenly see a patient who was doing well, okay, and who has not been following up with you, but and she's also stopped taking medicines. You can see sudden changes in respiratory, renal, hepatological, neurological, and cardiovascular systems as well. So what happens in the cardiovascular preeclampsia patient are more prone to pulmonary edema because there is a reduced colloid oncotic pressure. So in preeclampsia, in normal pregnancy, in antepartum period, the normal pregnancy, the colloid oncotic pressure is 22 millimeters of mercury, and postpartum it is 17 millimeters of mercury. But in preeclampsia, as you see, it is decreased. So it causes more perfusion. It is more permeable. The arteries are more permeable for the transfusion of fluid from intracellular to the extracellular compartment. Okay. Again, in cardiovascular system, there is increase in pregnancy in general. There is increase in cardiac output. But if you now complicate that pregnancy with preeclampsia, there's going to be increase in peripheral vascular resistance. Okay, there's going to be increase in afterload. So it might cause pulmonary. It might cause concentric left ventricular hypertension. So patient who usually were having mild heart diseases will start showing you severe consequences of that. Okay, it will be taken a notch up. Okay. So initially there is increase in cardiac output, but at the later stages of pregnancy, because of the severely increased and if the BP is not well controlled, the cardiac output also eventually starts gradually decreasing at the end of the pregnancy. Respiratory, airways are edematous. There is a small ET tube, increase in risk of pulmonary edema of almost up to 70%. So we patients with PIH, you have to be careful with specifically with fluid overload, because it might cause pulmonary edema in such kind of patients. So fluid restriction Okay, you have to be very careful with the hemodynamic management of this kind of patients. Okay, in renal, there is decrease in renal blood flow. GFR is decreased. Renal failure may be due to decrease in plasma volume and renal artery vasospasm. Proteinuria is there. A lot of proteins are lost. So basically, once a lot of proteins are getting out of the body, there is less proteins in the intracellular compartment, because of which there is a shift of fluid to the extracellular compartment in such patients. That's why you see that patient have become they have pedal edemas. Okay, because there is stagnation of fluid in the extracellular compartment. So renal functions recovers quickly postpartum. As soon as the placenta is delivered, the renal functions come back to normal. Hepatic is right upper quadrant pain is a serious complaint. It's a warrant sign, okay, especially when accompanied by elevated liver enzymes. So HELP syndrome is basically states hemolysis, elevated liver enzymes, and low platelet count. It can cause almost 20% of the uncontrolled preeclampsias might land up into HELP syndrome. So in coagulation, generally hypercoagulable state, like platelet activation is there. There is increased fibrinolysis. DIC may occur and platelet count starts gradually falling, and once it starts falling less than 1 lakh, it is a red flag. Okay, and DIC may occur and placental abruption might also take place. Neurological symptoms like there's headache, there's visual changes, there's seizures, there's diplopia. Okay, there's hyperreflexia, there is exaggerated deep reflex. Eclampsias may occur and with the BP raised, or even sometimes without the BP extremely raised. Okay, possible causes are due to hypertensive encephalopathy, cerebral edema, cerebral ischemia, vasospasm. Basically, it is due to glutamate that has been released, which causes arrhythmic firing of the neurons. Then, what are the investigations that you have to do in such kind of cases? So, there is full blood count with platelet count. There is LFTs, RFTs, 24 hours urine output. Okay, then obstetric scan and uterine artery Doppler. Now, management of pregnancy with preeclampsia. Now, when the patient comes to you who has been diagnosed of preeclampsia, you have to start looking for the red flags. Patient comes to you saying that, okay, now she's having a little bit of headache, or she's having double vision, or she's not able to see blurry. There is blurring of vision with her. Initially, this was called as an imminent eclampsia. The patient is imminently going to go into eclampsia. Such kind of patients, you need to admit those kind of patients immediately, and you have to give a prophylactic dose of magnesium sulfate. Okay, loading dose of magnesium sulfate has to be given to avoid seizures. Okay, if the pregnancy is less than 26 weeks, you will have to consider termination of pregnancy regardless of whether the viability of fetus is there or not. From 26 weeks to 28 weeks, you can try to prolong the pregnancy. We can try to give corticosteroids, and we can try to control the BP. Once the patient is admitted, you can start giving the first line of treatment like labetalol. You can add Nephilipin as the second line of treatment. Try to preserve the pregnancy as much as possible. If the symptoms are still there, you have to terminate the pregnancy, give corticosteroids for the fetal lung maturity, and deliver the baby. Usually it is said for severe preeclampsia, 34 weeks is the limit. For mild preeclampsia, 37 weeks is the limit. The most difficult part in our nowadays life is to convince patient to get admitted. Patients know, okay, now their EDD is at 38 to 40 weeks. But when you tell them, okay, at 34 weeks or say at 30 weeks also that BP is raised, you have to convince the patient to get admitted. Patients are usually reluctant to get admitted so soon. Their question is, doctor, my delivery is after 2 months. You're asking me to get admitted for 2 months and then you're going to deliver my baby. You have to, here is where the doctor communication, the good counseling comes in play. Patient usually come to us saying that, doctor, we have our grandfather and grandmother or my mom or my dad, even they are having hypertension, they are taking medicines and they're at home. Okay, even if I'm having hypertension, why can't you just give me medicines, and why can't you ask me to monitor my BP? I'll come every once a week to check my BP, and if everything is fine. For such kind of cases, you need to tell them the severity. You have to tell them there's a big role of patient counseling. You have to counsel the patient, stating that the complications that can happen, and suddenly how a patient with mild preeclampsia can deteriorate into severe preeclampsia and eclampsia, and there can be fetal death. You need to tell the patient that we have to admit the patient for her own sake as well as for the fetus. We need to keep on monitoring her fetus Doppler, for fetal heart rate. We have to keep on monitoring her urine output as well as her urine protein levels. At any time this changes start taking place, patient is better managed in a hospital rather than at home. At home, patient will never come to know whether her protein urea levels have increased, she's having oliguria. Usually in Indian, patients are not very aware. You see at the rural side, patients are not very aware. Okay, they will try to prolong as much as possible because they don't want the financial constraints and financial burden on the family. So they try to sleep it off. They don't try to tell you few symptoms such as patient was feeling vomiting, there was a projectile vomiting, or there was headache. Usually patient say that, okay, I was having headache probably because I was having tension. That is why my BP went up, and that is why I was starting having headache. So such patient need to be counseled that headache in pregnancy with the raised BP is always a concern. It is not normal. It is not normal to have that. Patient needs to be admitted, and then treatment can be given. Even in cases of mild preeclampsia, patient needs to be admitted initially. Patient need to be started on antihypertensive medication, corticosteroid if necessary needs to be given. Okay, loading dose of magnesium sulfate can be given for neuroprotection, not for convulsions if the BP is well controlled. And after a few days, if the parameters are remaining normal, if there is no proteinuria, patient can be advised to go home only and only if a patient is ready for a strict follow-up. Okay, this is what we can do the best, but yes, we need to take consent saying that we as a doctors would recommend patients to stay admitted till the delivery. Okay, for moderate and severe hypertension, there is no chance that you can ask patient to go home with BP more than 150 by 100. Okay, you need to start patient on antihypertensive medication. BP has to be monitored at least 4 to 5 times a day. And proteinuria every morning, you have to do every 24 hours, you have to do a urine dipstick test, as well as 24 hours urine has to be monitored. Anytime you start feeling the output of the patient has started decreasing, or the dipstick score has started increasing from +1 has become +2 or +3, you need to get a Doppler studies done. You need to check whether the fetus is also how is the fetus doing. Okay, weekly scans or every fortnight scans can be done to check the fetal Doppler studies. Okay, and if the BP is not getting controlled, you need to take a decision to deliver the baby. All right. So diagnosis criteria is proteinuria more than 300 mg or +1 reading, serum creatinine more than 1.1, platelet count less than 1 lakh, and elevated SGOT SGP. So what are the treatment objectives? First is to stabilize hypertension and to prevent the severe consequences. Okay, sequelae of HDP. Second is to prevent the complication. Third is to prevent eclampsia, deliver a healthy baby, okay, and restore the health of the mother in puerperia. So what are the drugs commonly used for severe eclampsia? In cases of severe preeclampsia, you can start with 20 mg IV labetalol. Okay, repeat. If the BP is not controlled within the next 15 minutes, repeat 40 mg. Okay, again wait for 15 minutes. If the BP is not controlled, again repeat a dose of 40 mg. And if still not controlled after more 20 minutes, you can start with a dose of 80 mg. Maximum dose is 220 mg injectable, and oral for patients whose BP is well controlled. So we can start with 100 mg twice daily. Okay, for initially, and you can increase the dose for 200 mg to 2400 mg per day divided doses. Okay, in 2 to 3 divided doses. Hydralazine is another intravenous drug that can be given 5 mg every 5 to 10 minutes. 5 mg can be given every 10 to 20 minutes and maximum to 20 mg. Okay, most commonly used is Nephilipin. It is given only in oral form. Usually, initially it was also given sublingually, but sublingual can cause sudden postural hypertension. So usually we give 20 mg stat and repeat the dose every 2 to 4 hourly and maximum 180 mg per day. Initially the alpha methyl dopa was also used, but nowadays it is not used. 500 mg 3 to 4 times a day was given, but then it started causing basically central nervous system depression, okay, constipation, and there are many more side effects that we'll discuss in coming slides. So the mode of action, methyl dopa is simply acting agonist, alpha agonist. Starting dose initially recommended was 250 mg BD. Now it's 500 mg BD. Maximum dose 1 gram PDS, and contraindications cause depression. And it is safe to be given in during breastfeeding. Labetalol is the first drug of first line of action. It's a golden drug nowadays, commonly used. Alpha and beta agonist, 100 mg twice a day. It can be given. Only contraindication is asthma. Nephilipin is a calcium channel blocker, so it basically decreases the calcium influx into the vessels, because of which there is vascular dilatation. Usually 10 mg BD is a starting dose. It can be given up to 40 mg BD or into 20 mg TDS can be given. Hydralazine is a vasodilator, arterial dilator. 25 mg TDS divided forms can be given. But basically, as we have seen, labetalol IV does respond. Patient do respond well to labetalol intravenous infusions and labetalol oral. And next drug is Nephilipin, calcium channel blocker, which usually these two drugs are more than sufficient. Sometimes, yes, we do need to keep the patient on two oral drugs, that is labetalol and Nephilipin. The role of alpha methyl dopa and hydralazine have decreased over the years now. So this is the treatment protocol: hydralazine 5 mg IV or 10 mg IM. Repeat after 5 to 10 minutes at 20 minutes intervals as needed. No response after 20 minutes, give 20 mg IV again or 30 mg IM. For labetalol, again 20 mg IV bolus to start with. Further, after 10 minutes, give 40. If it is BP is not controlled, again repeat the dose of 40. If it is not controlled, after 10 more minutes, and final dose will be 80 mg. And usually we have seen that after first 20 mg or else the first 40 mg, the BP usually comes down. Maximum dose is 220 mg. If it doesn't get controlled by then labetalol, then you can shift to hydralazine. Next dose is Nephilipin, 10 mg to start with, and every 30 minutes you can initially give oral Depin till the BP is controlled. And next, the clinical data, the trials have been conducted to see the compare labetalol with Nephilipin. Labetalol and Nephilipin both have shown to be both shown to be effective to control the hypertension. Labetalol achieved control significantly more often with starting dose and had fewer side effects. So why not alpha methyl dopa? Because the side effects are more relevant nowadays. It causes dialectic postpartum depression. There is constipation. There is altered sleep pattern. There is headache. It usually masks the system, masks the changes of eclampsia. There's hematological manifestation like hemolysis and thrombocytopenia. And sometimes it also alters the fetal heart rate. Now, role of magnesium sulfate. Like magnesium sulfate has been known as a magic drug. So magnesium sulfate causes benefit to both mother as well as fetus. So in fetus, it is usually given for neuroprotection, and magnesium sulfate given to a mother also causes membrane stabilization. It's a membrane stabilizer. Whatever dysarrhythmic glutamate secretions are going on in the brain, which causes firing of the neurons, is usually countered by giving magnesium sulfate. So usually we use, there are almost 27 regimes of giving magnesium sulfate. Most commonly followed and most effective is magnesium sulfate given by the Pritchard's regime. Okay, and for that usually we give 4 grams IV diluted with 12 cc of NS over 4 to 5 minutes slow IV, and then 5 gram in both the buttocks. Okay, in cases of eclampsia, this is only for eclampsia. deep IM injections are given, and we have to keep on monitoring the deep tendon reflex in such cases, because if the deep tendon reflex starts vanishing, or it becomes the patient starts to become more lethargic, okay, you need to skip few doses. Okay, even if the urine output is not significant, urine output should be more than 30, because magnesium sulfate strictly follows the renal clearance. It comes out only from kidneys. So if the urine output is less, you need to skip few doses every 4 hourly. Usually, magnesium sulfate has to be given deep IM. But if for the maintenance dose, but if the urine output is less, you have to repeat the creatinine levels. Okay, you have to repeat the RFTs, and you have to hold that dose of magnesium sulfate and probably give after 2 more hours. Okay, so what are the indications for a severe preeclampsia, eclampsia? Okay, nowadays it is also recommended you can give in cases of mild preeclampsia in labor, because in labor the BP is going to shoot, patient is going to be in pain, so a patient might suddenly throw convulsion, so it is given. And another indication is a fetal neuronal protection. So what are the complications now? So complications are, there is severe eclampsia, DIC, HELP syndrome, placental abruption, there is liver infarction, there is pulmonary edema, increased maternal mortality. Okay, there can be for fetus, it can be prematurity, there can be oligohydramnios, there can be fetal growth restrictions, and there can be fetal death. So what are the anesthetic goals in labor? Now, on the mode of delivery for preeclampsia patient is not, there is no indication that preeclampsia patient has to be delivered only and only through cesarean section. Normal delivery can occur if a good anesthetist is available and patient is tolerating the uterine contractions pretty well. There is dilatation. The Bishop score is good enough. Patient already in labor, and fetal parameters are normal, provided the NST is reactive. In such cases, normal trial can be given and patient can be delivered vaginally. So anesthetic goal should be to establish and maintain hemodynamic stability, control hypertension and avoid hypotension, to provide excellent labor analgesia. Yes, in such cases, epidural analgesia can also be given. Okay, to prevent complications of preeclampsia like intracerebral hemorrhage, renal failure, pulmonary edema, and eclampsia and convulsion. And you need to do this in cases where patient can be quickly taken for cesarean section if the fetal heart rate drops, or there is poor Bishop score, or else the baby has passed meconium. In such cases, quickly the patient can be taken for cesarean section. In such cases, only in such institutes, trial for labor should be given. So hazards of general anesthesia, first of all, airway edema is more common because there is profusion of fluid into the extracellular spaces. Mandatory to examine the airway soon before the induction. The laryngoscopy and intubation may be difficult because there is increase in BP. There is labetalol or nitroglycerin can be given, okay, to decrease the BP by the anesthetist. So timing of delivery. So gestational hypertension can be taken to term if there is no proteinuria. If the gestational hypertension is well controlled, even the chronic hypertension, if well controlled, can be taken up to term, okay, or can be waited up till patient goes into labor. It's usually recommended not to push the pregnancy beyond 40 weeks, like for other preeclamptic cases. Usually, sometimes some obstetricians they push the pregnancy beyond 40 weeks till the patient goes into natural labor. But in cases of preeclampsia, in cases of gestational hypertension, which is well controlled, it is recommended not to push it beyond 40 weeks. You should induce the patient up to 40 weeks at least. In mild preeclampsia, patient should be delivered at and around 37 weeks. Okay. In severe cases, the patient needs to be delivered up to 34 weeks. Preeclampsia should be delivered once, stabilized with magnesium sulfate at any weeks of gestation. So there is no expectant management for eclampsia. The only treatment for eclampsia is delivery of the baby and the placenta, regardless of the gestational age. Mode of delivery, yes, we can choose the mode of delivery. Bishop score has to be assessed. The fetal parameters have to be assessed. If the patient is already in labor, patient is already well dilated, yes, we can give trial of labor, we can keep on monitoring the vitals, and we can try to deliver the baby vaginally. Okay, then the corticosteroids have to be given for fetal lung maturity. Dexamethasone 6 mg 6 hourly 4 doses, or injection betamethasone 12 mg 12 hourly 2 doses. Betamethasone, the recent studies say that betamethasone 2 doses are more better than dexamethasone 6 doses. Either which ways, both are equally effective. So cesarean section has to be done only for the obstetric indications only, like if there is cord prolapse, there is abruption, okay, there is or else there is malpresentation, and only in such cases cesarean section can be done, or vaginal trial can be given. So note that lower BP promptly but slowly. Aim for BP should be less than 150 by 100 of mercury. Loading the dose of magnesium sulfate is recommended to prevent eclampsia, and in cases of severe preeclampsia as well. No need to maintenance dose in such cases. If patient is just having imminent eclampsia, no need to give maintenance dose. Once the patient's BP is controlled and patient is ready for delivery, you can just monitor her vitals. Expected management is done of severe preeclampsia only and only at tertiary center. There is and can be done when there is no maternal organ involvement, there is no imminent danger to the fetus, and you have to or else to give steroids for the lung maturity of the fetus. So in conclusion, preeclampsia is a serious multi-organ system disorder of pregnancy that continues to defy our complete understanding even today. Like I said, it is the worst nightmare of an obstetrician. Okay, for a physician, BP of 140 by 90, physicians usually say, okay, it's not a big deal. It's 150 by 100 is also fine. But obstetrician knows that BP anytime starts raising above 140 by 90, it is very serious complications. We have seen cases of eclampsia, we have seen maternal mortalities occurring, we have seen postpartum hemorrhages, sudden fetal losses. So 140 by 90 might be normal for a physician, but never is normal for an obstetrician. It is characterized by global endothelial cell placental endothelial cell dysfunction. It may, the cause still remains unknown. They are still trying to find out. There is a placental theory, there's immunological theory. Still, nothing has been proven yet. So there is no effective prophylaxis. Only aspirin and ecosprin injections can be given. Low molecular weight heparins can be given, so that there is no hemoconcentration and there is less chances of hemolysis. Delivery is often only cure for this. Once the placenta has delivered, we have seen that the BP usually comes back to normal. Magnesium sulfate is now proven to be the best medication to prevent and treat eclampsias, because it is basically for both mother and fetus. It is stabilizes the neurons. Epidural analgesia for pain management vigilance have been beneficial effects have been seen, and it is preferred. So thank you. This will be all. I'd like to take your questions.
Thank you, sir. Thank you very much for that wonderful presentation, sir. Sir, let me wait for 1 or 2 minutes for the participants to post their queries, sir.
Sure, definitely.
If there is any queries, I'll read it for you, sir. Sir, when it comes to these calcium channel blockers, that is Nephilipin, whether it is safe, sir, or only Nephilipin is allowed, sir?
Nephilipin, it is safe. It's just that it causes sudden hypotension if given sublingually. That is why people usually prefer giving labetalol, because more effective, it is longer lasting. Okay, Nephilipin sustained release capsules are also available. Nephilipin, if given orally, Depin 10 mg definitely brings down the BP drastically, quickly. And yes, Nephilipin is certainly very helpful.
Yes, sir. So second question is, what about the dose of aspirin to be used, sir? In cases where we usually suspect patients, like the high risk factors,
patients who are pregnant less than 18 years or patients who are more than 35 years, ART treatment has been taken, patient has conceived after an IVF cycle, obesity is there, diabetes is there, any such high-risk patient, 60 mg daily dose is recommended. Now it is 75 mg. 75 mg daily is the ecosprin dose which is recommended nowadays.
Right from the if the mother is having hypertension, right from the first semester they can start, sir?
Yes. Ecosprin needs to be started as early as possible. Usually nowadays there is a test called as which is called a predictor test, SFLT upon PLGF, which we usually do at our institute. We usually do this test at around 12 to 18 weeks. We do this test, which it is one of the tests which is a predictor. It is which gives predictions basically that patient might land up if the PLGF is more and SFLT is more and PLGF is low. Okay, it means that there is a high risk that the patient is going to land up into preeclampsia eventually in the later stages of the pregnancy. In such cases, usually we start with ecosprin tablet 75 mg once daily.
Okay, sir. Sir, if the patient is diabetic and if she is hypertensive, what drug will be the best choice for them, sir?
Yes. So in such cases, if the patient is hypertensive and diabetic both, first of all, both patient is now having two risk factors. Patient has to be started on ecosprin as soon as the pregnancy is diagnosed. Okay, if the pregnancy is less than 20 weeks and if the hypertension is well controlled on labetalol, patient can continue with the same dose. Okay, for diabetes, patient has to be given MNT, medical nutritional therapy, as well as patient needs to be OGTT and GTT has to be done to see the patient's insulin tolerance, and if need be oral hypoglycemics or insulin therapy needs to be started for such patients. If the diabetes and blood pressure are both well controlled, pregnancy can go up to 37 weeks. After 37 weeks, you need to deliver the patient. In either cases, up to 34 weeks, if the BP is not well controlled or the sugars are going haywire, you need to deliver as early as possible. If the patient starts showing the changes of imminent eclampsia or patient starts showing Doppler changes, then we have to deliver the baby even earlier. Corticosteroids in such cases are still given. Yes, corticosteroid will cause shooting up of sugars in this kind of cases because the patient is already diabetic. So corticosteroids should be given once the patient is already admitted and the sugars are well monitored. Then the doses are again rearranged, and then patient can be then the patient's doses can be rearranged again. Any more questions?
Last one, yes, sir. Last one question, sir. Like whether you can try any diuretics in pregnant mother, sir?
Usually, what happens is diuretics come into play once the delivery is done to avoid pulmonary edema. Okay, furosemide and other hydralazines are better given once the patient delivers. So, in cases where patient is having eclampsia, severe preeclampsia, patient has delivered now, and the urine output is less. In such cases, yes, we need to. In that cases, we can give furosemide. You can give diuretics in such cases.
Sir, thank you, sir. There is no more other questions in the chat box, sir.
Okay.
So if you allow us, then we can end the webinar for today, sir.
All right. Thank you so much.
Yes, sir. Thank you. Thank you very much for your wonderful presentation.
Thank you, sir.
Sir,
Thank you so
once
much.
again, thank you for spending your valuable time with us today, sir. Thank you very much. I would also like to thank the audience for their active participation, sir. Thank you.
Thank you, everyone. Have a nice day.
Good day, sir.
Have a good day.